Perfect. So this is being recorded. Hello, everyone. We will be talking today. We're going to try to do, I think the plan was to review some of the concept of shock in a newborn. So I thought of starting with, first of all, what's the definition of shock? Anyone can answer.
Inadequate circulatory perfusion.
Okay. So what do you mean by that? Yeah.
It's O2 supply that does not meet the demand.
Perfect. So there's a
Depending on the
mismatch between oxygen delivery to the tissues and the actual metabolic demand of the tissue, which eventually can lead to ischemia and then cellular failure, and eventually you get necrosis. And in the NICU, we'll be facing different types of shocks. So maybe you can just give me like a sense of how you organize your approach to what could be the different etiologies of shock.
distributed.
So hypovolemic, cardiogenic, distributive,
Neurogenic.
obstructive,
Neurogenic.
neurogenic. Often neurogenic goes into the distributive,
Yeah.
but you're right to say that there are certain pictures of neurological disturbances that can lead to different types of shock pictures or a mix of them. So often neurogenic shock is what we mean by like spinal injury, which we can see during birth trauma, and then they lose some of the sympathetic tone to the rest of the body, and because of that, they lose a lot of their systemic vascular resistances and control over that, and they can lose also the matching between heart rate response to provide more stroke volume. So we know that stroke volume is being generated in part by contractility, in part by heart rate. So you get the cardiac out. So for your cardiac output is a function of your heart rate and your stroke volume, and this stroke volume is then eventually influenced by what? Afterload. Perfect. Great. So, and then your stroke volume times your heart rate will give you your cardiac output, whether it is LV and RV. Typically, we match 1-to-1. We call this the QP to QS ratio. Many of our babies have shunts, so they may not have this matching. So we'll talk about the right ventricular output and the left ventricular output if they start having these shunting at different levels. Or if they're a single ventricle, then we talk about the combined cardiac output. Once you have a cardiac output, this cardiac output multiplied by the resistance of the vascular network plus the drainage pressure will give you the blood pressure you will be measuring upstream. So typically we talk about a mean blood pressure equal, for example, if it's mean blood pressure in your aorta, it will be equal the cardiac output of the left ventricle, if your left ventricle is the systemic ventricle, times the systemic vascular resistance, which is basically the total peripheral vascular resistances. If you have the lungs and the system that are connected to each other by a shunt, for example, truncus arteriosus, AP window, PDA, you'll end up having to account to some degree also the pulmonary vascular resistance in this equation. And so plus the drainage pressure, which is the right atrial pressure, okay? Sometimes your right atrial pressure doesn't fully represent your draining pressure of your system. In which situation can that occur?
You want again, sorry?
Sometimes the draining pressure does not represent what you measure in your right atrium. So in which situation the systemic venous pressure, or like let's say you can have congestion with a low right atrial pressure. What could be an etiology for that? So think about your highway. So your blood flow is going through your capillary, let's say in your legs. It then drains into veins, and then these veins will join into what kind of structure?
The anomalous venous.
No. So think about you're draining into like big veins, iliac veins, and eventually to the IVC. So what could happen along that path that could be a problem and that would not reflect like right atrial pressure?
Cardiac.
So how can you obstruct a vein?
thrombosis.
Thank you.
Yeah.
So in adults, they see a lot of deep vein thrombosis. They see a lot of clots that are coming to your liver, blockages. We had a patient that had a UVL that created a massive clot, and actually we had to go to the cath lab to open and do a stent. Why? Because he started developing these massive ascites. So there's high draining pressure. And these patients, some of them can become hypertensive, or they can eventually become hypotensive because of the ascites. They lose preload, they become dehydrated, they lose cardiac output. Does that make sense? We more frequently in our context will see issue with draining pressure and the RA is not the same as the systemic venous pressure. If, for example, yes, you have a tension pneumo, so you're blocking venous return. So your RA, but typically your RA pressure will increase as well. But another element, because it's in the chest, right? Abdominal compartment syndrome. So if you have a severe neck perforation, the pressure starts increasing, or gastroschisis, for example, you can dramatically increase your venous return pressure, but your RA pressure will be low because there's less preload coming to it. So just always think about where the red blood cell is going. Okay. The most typical cause of a rise in right atrial pressure is when you have what we call RV failure. So you have increase in your RV end diastolic pressure. The compliance of your right ventricle will start to be impaired. And so when the tricuspid valve opens and the right atrium is faced with the pressure inside the RV, this right atrium, first of all, may not be able to eject its content. So the right atrial pressure may rise. So be aware of that because in the IC, in the PICU, they'll often have central line and they'll see the central venous pressure and they'll use that to gauge does the patient, for example, needs more volume. If the central venous pressure starts dropping, then it's like one of the correlative preload. Another thing, they'll see that when you have right heart failure, so pulmonary hypertension, for example. Or if you see another example where your CVP may start rising is in patients who have like torrential flow lesions, so vein of Galen, or terrible hepatic hemangioma. They may have so much flow coming back to the right atrium that the right atrium, at some point, it's a structure that can accommodate a lot, but eventually may not accommodate as much and the pressure will start rising. So if you've put a UVL on a baby with a torrential vein of Galen malformation, get ready, it's going to bleed a lot because the pressure is so high. So it keeps on bleeding, bleeding, bleeding. So you have to be very ready to tighten it up or to suture it because you do put your central line, but it's like almost like a pop-off. You're popping off the pressure that is so high in the right atrium. Okay, so just be aware of these little things. Okay, so shock is this mismatch. Typically, we talk about cardiogenic, distributive. Just gonna open one thing. And you said septic shock. Septic shock is an etiology often, and it can encompass some of these mechanisms that we try to categorize in these different patterns of phenotype. So I'm going to share, if you see my screen. Oops, that's not what I want. Yeah. So if you go into the types of shock that we often see, so hypovolemic is like dehydration. So preemies can get very dehydrated, like they pee a lot or they have a lot of insensible loss by their skin or by their airway, or they may lose a lot via urine output. You mentioned you can have bleedings. So you can bleed in your head, you can have pulmonary hemorrhage, you can have a fetal-maternal hemorrhage, you can have a cord accident, an abruptio, a previa, so they can bleed a lot there.
Capillary leak as well.
Yeah, so lymphatic disorder or capillary leak, so sepsis, SEERS, HLH, hydropic patients, they lose a lot of their preload because everything leaks like from the lymphatic, so Noonan syndrome, all these rhizopathies. So that's common in dehydration state. And then if we haven't gauged how much balance we needed to give, and then we kept on giving diuretics and trying to neutralize the patient, and eventually he's very low in intravascular volume, that could lead to preload dependency. Distributive, what is distributive?
Third spacing.
But what does distributive mean?
It's like the resistance is different.
It's a loss. It's an abnormal loss of the total peripheral vascular resistance. So suddenly, all your network vasodilates abnormally. And so this autoregulation mechanism to maintain perfusion pressure is lost. That's typically because of which conditions most of the time? So sepsis, so typically bacterial sepsis, so E. coli, gram-negative sepsis. Sometimes we see that with Candida, herpetic, enterovirus can cause sometimes that. Although enterovirus, it's most often a cardiogenic, but it could still give like a severe inflammatory syndrome. EBV, CMV, they can cause this. Okay, what other cause that are non-infectious that can cause a distributive shock in a newborn? Anyone online can also participate.
Steroids, maybe?
So the lack of steroid, so someone who's going into an adrenal crisis can have vasomotor instability and they can present like this. What would
Neurogenic, if there's
neurogenic? So if you get transection of your spine during a birth trauma, we've seen it. Yeah. What else?
if you give that many like medication like
Hypergenic. So PGE, infusions of vasodilators, you're giving a beta blocker, you're giving agents that's going to be, tons of phenobarbital and phenytoin. So we see it classically with a lot of our HI babies. They already have autonomic dysfunction, and then you kind of bombard them with some of these agents that can vasodilate. Okay, what other etiology? Anything else you have in mind? I mean, the list is there, but
Anaphylaxia.
anaphylaxis, very rare in newborns, but definitely
Yeah.
anaphylactic reactions. So we can see that in like, for example, incompatibility of blood transfusions. They can get this. So think about it if you see suddenly a baby that's like collapsing during a transfusion for some reason. Something rarely that we see here, but we see it is neonatal Graves' disease. When they have like this thyrotoxicosis from maternal TSH expression, they can get this picture of distributive shock. Then the other one is what?
types of shock?
Yeah,
or
types of shock.
cardiogenic?
Cardiogenic. So what's cardiogenic? But what does that mean?
An ability of heart to pump the blood to the body.
Exactly. So the heart has inherent properties of contractility. You remember the actin myosin with Dr. Volichek that was talking about that. And then when you start having any process that will alter this capacity to actually contract and relax, you enter a picture of what we call heart failure. And when it gets to a point that this heart failure is not able to generate enough stroke volume to have a cardiac output that is matching your metabolic demand, then your etiology of shock or part of your etiology of shock, because you can have mixed picture, is a cardiogenic picture. So these patients have typically systolic dysfunction or systolic diastolic dysfunction. They may have very high end diastolic pressure in their ventricles, so it creates mural wall tension. So because of that, the microcirculation of coronaries becomes impaired. So on top of it, they get a component of ischemia of their myocardium. So that the etiologies there's so many, right? I'm not going to go in all of them. Acidosis, poor calcium, metabolic disturbances, carnitine deficiency, hypoxic ischemic encephalopathy, intractable PGRT arrhythmias, dilated cardiomyopathy, hypertrophic cardiomyopathy, viral myocarditis. You can have some congenital heart defect that are causing cardiogenic shock. So if you had, like, for example, an LV obstruction, aortic stenosis, coarctation with PDA, closure, systemic hypertension, post-ligation syndrome, where suddenly your LV is facing very high afterload. Al-Kappa, do you guys know what Al-Kappa? What's Al-Kappa?
It's where the coronaries develops from the pulmonary vein, not the
Pulmonary artery.
instead of the vein.
Exactly. So when the PVR are dropping, suddenly the gradient for the flow of resistance disadvantages the coronaries, and actually they're not able to perfuse sufficiently the myocardium. And then you can have clots in these coronaries. You can have a clot in your LVOT. You can have obstruction to your LVOT by dynamic obstruction in infant diabetic mother, for example, that can eventually impair coronary perfusion. So there's many, many causes of things that can cause cardiogenic shock. We simplify it by saying cardiogenic, but typically we'll look at the right heart, the left heart, or the biventricular function. And you may have components of each of these conditions, right? And obviously they come hand in hand. You'll have a lot on cardiogenic and how to recognize these different things. Obstructive. What's obstructive?
Pericardial effusion.
What did you say?
Pericardial effusion.
So pericardial effusion that leads to tamponade physiology, and we'll talk about the difference between the two. because you can have a pericardial effusion with no tamponade. Pneumothorax, pleural effusions that are massive, chylothorax, chylous effusion, thrombosis, typically in the pulmonary artery, but it can happen in the aorta if you have a massive clot in your aorta for some reason. We've seen that with UALs, like big clots that come and you can necrose some of your organs because of that. This is very bad prognosis. And then, yeah, sometimes some people will include some of these obstructive congenital heart defect in the obstructive, but it's like a mixed cardiogenic obstructive, just because there's an element of this obstruction once you address and you give PG. Okay, the last one we often don't talk about. It's very rare, but there's another category that we call dissociative. Have you ever heard about that?
It's not extra.
Yes.
Cyanosis, cyanide toxicity.
Yes. Carbon monoxide intoxication, cyanide, methemoglobinemia. It's very rare, but technically, if you would be very intoxicated, you can have issue. And then one other element is when you start impairing your mitochondrial function. So the most common cause of dissociative shock that we see in the NICU is LPS-related sepsis. What is LPS? It's the E. coli and gram-negative agent that is being released. And this LPS, one of the things it does is actually it shut down the mitochondria. And so even if you're able to reestablish perfusion pressure, your blood pressure, that you're able to reestablish flow to your organs, it's like the cars are passing in front, they have oxygen in it, but no one is picking up the oxygen, they're not able to use it. And so these organs are eventually, dying and they create anabolic reactions. So you see a lot of lactate increase and eventually you go into cell necrosis and death, tissue death. Okay, so these are the types of shock. So case number 1, because it's been 20 minutes, we reviewed already the types of shock. Okay, so you're called at the bedside of a preterm patient who was previously well on CPAP, 27-weeker. This kid is maybe 7-day-old. So he has a TPN. It's administered via PICC line because the UVL was previously peripheral. He's progressing on feeds. He was doing relatively well in 25% oxygen. But the nurse starts noticing the baby is having significant events, so comes to evaluate the patient and finds the baby to be very blue, gray, mottled, and calls a code because obviously at that point the baby is barely breathing and she has to PPV. The blood pressure is being done as we speak. You have 42 on 36. As you arrive to evaluate the baby, you see a baby that's poorly reactive, who has weak pulses, very mottled, very cold to touch. The heart rate was oscillating between 180 to 185. It's not regular. It's fluctuating in time. Oh, I hear myself. Okay, all good. And you decide to emergently intubate the patient because he's constantly apneic. And then post-intubation, you're on 100% oxygen. Your saturations are dropping in the 90%. You have no pre- and post-ductal sat differences. The tracing on the oximetry is not great. You have very prolonged refill, like 7 to 8. And now your heart rate post-intubation is around the 140s. So what would be your approach to this patient at 3 a.m.?
You have a baby that has, I don't know how old the baby is and so on and so
7
forth.
days.
But the baby has some risk factors of having that PICC line that seems to have been there for a little bit, which sounds like this could be infectious. And
Okay, so it could be
obviously,
an infection.
yeah,
Okay.
it could be like a septic. It could be septic shock in this case, considering how the presentation is with a dramatic change in oxygen levels and a source of potential infection and the tachycardia. So I would probably stabilize the baby as you are describing already in the case, but also consider at least an infectious workup. This is probably one of the approaches.
Okay, so some of the tests you may want to send is like a
Like a
CBC, a blood
CBC,
culture.
yeah, exactly. Yeah.
Okay.
Yeah, maybe you
Sorry?
have to think. Maybe you have to think too in the PICC line, maybe in the insertion, in the position of the PICC line.
Okay.
Maybe it's a possibility that the baby had a taponamiento.
Yeah. So they did.
If
So the PICC line dressing was redone yesterday. They had an X-ray. It looked in good
and
position.
it's okay.
Yeah,
Okay.
and they had done it yesterday. The X-ray was done. All the, she tells you it's running fine. I didn't have issue infusing.
Maybe the CPAP is too high, and the
Okay,
baby could have a pneumothorax
perfect.
because
So
it's very fast.
yeah,
The presentation is very fast.
so you're thinking maybe there's a tension pneumo. So they're
Yeah.
listening. They do an auscultation post intubation. The tube is changing, and they have good air entry bilateral. That's her about that. So she was saying she wants to do an X-ray. She wants to make sure there's no signs of enterocolitis because it's day 7. This kid was feeding, so she's gonna put NPO. She's gonna put low wall suction. She's gonna start broad spectrum antibiotics, and we're talking about the choice of antibiotics.
So yeah, because of the abdomen, we'll put Piptazo. It depends on what I see on the X-ray, the chest and the abdo.
Would you put Venco because of this whole line
Because
placement?
of the line,
Okay. You would put Venco? I think
check.
here we use Venco because of our staff.
Has a line.
Venco in shock, right? The kid is in shock, not the. Okay. It's 3 a.m. So now, like, you're just think about really what you were doing now.
As a
The truth.
not as a
Yeah.
hemodynamic.
Yeah, and then we'll do like what a
Can we get a TNE? Are the fellows available?
You're on night and you're not on call with me, and let's say before you get the machine, what I'm just trying to show, like, what could it be? He's on 100% oxygen. Could it be IVH?
Yeah, so he's still on the 100.
Okay.
We're not able to win. He's still 100.
He's on 100, he's standing
Okay, what do you
85.
see on the X before Joe?
X-ray, you see normal gas pattern in the abdomen.
And no pneumo.
No pneumo.
Nothing on the heart.
Nothing
Well,
on the heart.
the-
The line doesn't look so bad.
The concern obviously is that if this is a baby that is preterm, I don't know how preterm, but has a PDA, and the PDA closed, and now you're suddenly dealing with a ductal dependent lesion that suddenly now is
Right.
yeah.
Could it be a congenital heart defect? So you have to think about that at day 7. It could be an inborn error of metabolism. So there's many things it could be. I agree with you, getting some sense by imaging of what's happening. And I think that's my pitch to show you that getting just a quick scan will inform you a lot. So I think we've gone through how this clinical picture could be almost any kind of the shock we described, except maybe the distributive picture. But it could definitely be a cardiogenic. It could definitely be a preload issue. It could be that he bled somewhere, like in his brain, like massively. So you would send a CBC, check the hemoglobin, but if it's an acute bleed, it may time to dilute. So then one of my questions I was asking, are you bolusing this patient? Are you going to bolus this baby? Are you going to give some fluids?
How many?
No more than 10.
10 cc per kilo, he's 27 weeks.
Yes, I would.
You bolus?
Yes.
You bolus?
Do a PIV, not the PIC line.
Not the pick.
Because-
Okay.
I would need more information to make that call.
You need more information. So thankfully, Ben and Laurence are on call and they bring the echo.
Okay.
So it's just a showcase. This is a real case. So it's like you Venco the patient, you Tazo, you X-ray, you've done tons of things, right? But probably getting the info would tell you that this patient has
Preload.
a pericardial effusion, right?
I
So what do we see on this? So anyone can,
even if I'm not.
yeah, you can see. So who can describe what we see on this view? Laurence, tell us. First of all, describe what's the
So
view?
this is an apical 4-chamber view.
Okay, perfect.
Uh,
What is this?
This is the right atrium.
What is this?
The left atrium. This is the L view, the R view.
Okay, perfect. Now, how would you describe, what is the extra cardiac findings that you would describe?
It's a very significant pericardial effusion.
Perfect. So you recognize this is pericardium because you see the white line that's here, okay? And you see the lungs that are here around, okay? And then the other thing, this finding here, what is this finding?
The atrial wall is being pushed
Inside
inside.
the atrium. Why do we see that?
Is it because of the pressure from the outside?
Right. So a pleural effusion means that you have fluid accumulating within your pericardial space. Sorry, pericardial effusion means you have fluid accumulating in your pericardial space. A pericardial tamponade is when this fluid has been circumferential and built pressure enough because the pericardial sac is not able to accommodate that much fluid. And the pressure is so high that it impedes venous return. The extreme of it, when it's very severe, is that you start seeing compression of your low pressure chamber, and the low pressure chamber in your heart is the right atrium and the left atrium. So this is a classical sign of tamponade. Okay, you don't always get these classical sign of tamponade. You can see that it's a preload disease. Means what? It means that because the RA and the LA eventually are unable to fill appropriately, they're not able to fill the corresponding ventricles, and then these ventricles go into very low output. Often these patients will compensate, and eventually they just crash. What could be etiologies of tamponade or effusion in a newborn?
Infection.
Infection, okay. What's the most common one that we would see in the NICU?
Is it because of the line?
It's most classically because our line is intracardiac and because the fluid that we run has an osmolarity that is high, so in the 1,200, 1,600. And because of that, you get transudation. It's not a perforation of myocardium. It's really a transudation through these very thin wall, through the concentration of and via osmosis. But obviously, as you said, it could be infectious. So you want to rule out an infection. It could be oncological. It could be metabolic. It could be chyle. So this could be a Noonan syndrome. It could be a patient with trisomy 21. They're at risk of having pericardial chylous infusion because of lymphatic disorders. So it's something you would send a cell count because if there's lymphocytes, you would call this chyle. And because this kid has been fed, you would probably see also triglyceride at this point. But if the kid was NPO, you would just see lymphocytes, okay? It could be blood. So here we care for babies that come back from cardiac surgery. They remove their pacer wires. You can start bleeding in the pericardial space. So if it's blood, if it's very acute, it's going to appear anechoic, which means it looks black because it's very fluid. If it's starting to clot, you're going to see a lot of bright little like rocks inside that pericardial sac. But usually by this time, these patients have been drained and everything because if it's tiny clots, it's not going to restrict cardiac movement. It's important to get all the views. Why? Because you don't want to confuse pleural effusion and pericardial effusion. So in that particular case, it looks very clear that this is pericardium, okay? But sometimes you'll have a lot of fluids here and maybe there's adherences and you don't see as much fluid on the other side. So it's important to get all the views. This is a short axis view from subcostal. And what you can appreciate very nicely, you can see the white line pericardium that is abutting to the liver. And you can see that the heart is floating all around, including the vessels. So that you would not see in a pleural effusion. Okay, and you see like this, that it's quite circumferential and up to the apex of the left ventricle. So you know that it's fluid that has accumulated within the heart pocket. Okay. This is more for TNE people. This is the example when you're in short axis from the chest. So you may not have access to the subcostal view for various reasons, but this is an example from the parasternal short axis view. Here, for more advanced people, what are we doing here? We are doing pulse wave Doppler of the inflow. I just told you that tamponade is a restriction to flow within the cavities. Does that make sense? So one of the criteria for tamponade, I'm going to share my screen so everyone can see. One of the criteria for tamponade, effusion. So you go into pericardial effusion. Yes. So you have multiple examples, but one of the criteria is what we call when you're breathing, you have some degree of variability of how the flow is coming to fill your different ventricles. Okay. You're not supposed to have severe or extensive variability. When you start having extensive variability, I don't know if you remember the pulses paradoxis, it's a correlate to that. When you start having extensive variability, it means that your heart is severely restricted in how it can do some filling. So when you have pericardial effusion and you're not sure if this could be a tamponade physiology or not, or contributive, especially if you have like a patient that's hydropic, there's effusions everywhere. So of course you're tapping maybe the lungs and things like that, but you see a bit of fluid around the heart, but you're not sure if it's contributive. You need to know, do I need to tap or not? So for you that's doing TNE, that's more advanced, one of the things we use is we look at the pulse wave Doppler in the mitral inflow and the tricuspid inflow. Normally, you're supposed to have less than 40% variability. What does that mean? It means you take the peak of the highest and the lowest velocity, you compress them. So you compress the time, you compress those cardiac cycles. You see they're all here. You look at the peak, you look at the lowest. If the ratio of these velocities is more than 40%, then it means you have too much variability. So let's say one was 100 centimeters per second and the other one is 40 centimeters per second, you have 60% variability. So that's very high. Okay. For the mitral inflow, the left side gets less affected than the right side, which is typically a lower pressure chamber. So we talk about 25% variability. Above that, it starts becoming concerning for a tamponade physiology. Okay. So right atrial collapse during ventricular contraction. So we know that during systole, your tricuspid valve is closed. So if your right atrium is getting collapsed during that time, it's a sign that it could be tamponade. If you have this kind of swinging heart, so sometimes we use the M mode through the heart to see if it's just moving into the pericardial sac. That's been described as a marker of tamponade. Changes with the respiratory flow. So even intubated, you might see some of these variations. So it's the Doppler surrogate of the pulsus paradoxus. Right ventricular collapse. So it means that when the RV is supposed to expand, it actually collapses again. So that could be a sign. Very distended venous return. So if you look at the SVC, IVC, and you see a huge IVC, huge SVC, and you see retrograde flow into them, that could be indication of tamponade. And then, and I already mentioned the flow. So how do we drain? We'll go directly to the procedure. Anyone has ever drained tamponade? On a mannequin. Perfect. So if the baby is, if you're doing chest compression, the baby is dying, you don't have the time to go and call cardiology or call like whoever that's going to take an hour to come to the bedside. You have to drain that. And so there's two techniques. One of the technique is to try to go blind. The other technique is to go with your ultrasound probe. So I would say if you have a lot of dexterity and you're able to use ultrasound to guide, for sure you can use it to try to follow your needle. But if you're more of a novice and we're doing chest compression, you just want to go and drain as much as possible. So the technique is outlined there. We're going to go through with the mannequin. So we can all come here just to see how it goes. Okay, and then we'll follow here. So, of course, the first thing is to thinking, okay, what's my etiology? If I think it's the PICC line, I'm going to stop infusing by my PICC line. Okay, eventually I'll deal.
Any chance you could move a little because you're in front of where the camera is right behind you? Oh, that'd be great. Thank you.
Okay, is it better like this?
Yeah, perfect.
Okay, so you have to stop running anything by your PICC line. So first of all, like, okay, you call a code, someone is bagging your airway, someone is going to be ready to do chest compression. Maybe someone is looking to do an intraosseous because at this point your veins are going to be very difficult to obtain. And I can tell you this kid will be preload dependent a bit, but you cannot really bolus by your IV. And at this point, there's no point of bolusing until you remove the extra fluid. So you'll need to remove the extra fluid. So it's a clean technique, okay? So I'll do it blind. I'll show it to you and then everyone's going to practice. So the CHOP algorithm, which is there, typically will say to bring the head of the bed about 30 degrees, which will help bring the fluid, especially if it's more of a dense fluid. We see dense fluids with infection, like purulent, and we see it sometimes if it's an oncological process. And then the idea is you want to use an angiocat. I'll open a few. These angiocat are, and you can use any of the angiocats, but most of these angiocat, the one that we have here, they have a chamber where you're going to see the reflux. So this is an angiocat, okay? And then they have this chamber that you're going to see a reflux. And then this chamber, you can actually connect it to a syringe, okay? The auto-retractable one will not have that, but you'll still see the gush of fluid coming back because of the high pressure. Okay. So we connect it like this. Then what you want to aim is that you look at where's my xiphoid process. Okay, it's here. So you have the nipple line. Is someone calling me?
Tell them it's an emergency.
Okay. So you have xiphoid process, okay? And then I'll have my bigger needle ready. Okay. Sometimes we'll even have what we call an IV extension to help us pull and push, especially if there's a lot of fluid. So I'll have it ready here. I'm wearing gloves. I clean a bit. It's a clean procedure. We're in an emergency. You aim to be, as you can see in the picture, 30 degrees. So it's 30 to 45 degrees from the skin. Okay. And then from here, you go towards the left shoulder. Can you see, Ben?
Yes, we can see.
Okay. So then I put my hand on the baby, I hold it here, and I'm gonna start enter. And as I enter, I pull. And as soon as I see fluid coming back, you advance a bit more, you push your catheter, and then fluid will start coming back. You put your needle away, you connect your IV extension, and then you pull your fluid and you remove the tamponade effect. I would say that in most baby, 3 cc to 4 cc is enough to remove the tamponade effect. There's not that much liquid around the heart that creates this tamponade effect. I'm giving you this number of 3 to 4 cc because sometimes you may have a bloody effusion. And then what you want to avoid is exsanguinating more the baby. Okay. So if you're doing it blind for various reasons, you want to make sure that you're not going to remove more than 3 or 4 cc if it's blood coming back. It could still be a bloody effusion. And then just 3 or 4 cc could be sufficient to reestablish normal pressure in the intracardiac sac. And then you would come back and recheck, do I still have fluid around the heart? If you do, then it means you were probably not in the right pocket and you were intracardiac. Okay. Why we use the angiocath method is that you want to avoid, as you're re-expanding, to have myocardial injury. So the idea is that the needle can always cause arrhythmias. You can cause like myocardial puncture. You can injure valves. So we use the angiocath, which is soft, which is going to sit into the pericardial space so that we can actually drain easily without having issues of perforating the myocardial wall. Is that clear? If I would use the ultrasound, what I would do is that typically I would take my phasor ray probe, which is this squarish probe, and then one of the good view is the subcostal view. So of course, this is a mannequin, so we don't see everything. And then from here, you would see your pericardial sac that's filled of fluid. And then you can use this, okay, to poke. And as you poke, you look for your needle. Like here, we're not going to see because this is plastic, right? So we're not going to see, but I think you can kind of see it. I don't know if you see that line. You see that line? Yeah. And then as you advance, you follow the line and eventually you're going to be in the zone. And then when you're in the zone, you remove the fluid. Okay. So we're going to each practice it once and try to do it together. So who wants to practice first? Monia can do it. Let me just prepare for you. Just so I see you do the technique from scratch.
Then you can put my EPA.
Yeah. Yeah, great. I'm going to have tons of EPA to fill now. Okay, let me do this. Let me remove this needle because I want to make sure no one is going to get injured. Okay. This is garbage. So for, empty that syringe. Let me empty it here on the towel. Here. So you prepare all your material already. So you don't need that much material, okay? But you just need to know what's going to be the sequence of things you're going to do. And then as Monia is doing this, what would you send this for like testing?
Cell culture, chemistry,
Perfect.
lipids,
triglyceride, and sometimes chylomicron, you can measure in terms of labs, but yeah, triglyceride, glucose. It will be the glucose of the TPN most of the time. And then sometimes you may need to send like, albumin, protein. You may need to send LDH, a bit like the light criteria on pleural effusion. Okay, you won't feel much but like they're here, like les mamelons, the nipples. And so your xiphoid is around here. Okay. So from here, so the way I recommend, hold it like this. Can I show you? I'm not going to poke. So you have your needle, you hold like this, okay? So either so that you have some stability, and as you're poking, you can remove and then enter with this hand. You see, with your left hand. Does that make sense?
Mhm.
Okay.
So it's the xiphoid.
Infra. So you have this, it's subxiphoid. It's just, you see, this is the coastal margin. It's just under the xiphoid space. You do 30 to 45 degrees, okay, 30 to 45 degrees, and your directionality is towards the left shoulder. Okay? You have fluid coming back.
Yeah.
Wonderful. So then you connect your IV extension that's ready. And then as you connect this, now you pull. Yeah. And then the reason we do that is that right now I put a 30 cc syringe, but sometimes
Not
you'll
too much.
not much. Maybe I drained already a lot. Yeah. Try to redo with 45 degree. Let me take this. Let me take this. Okay. Redo, but try to go about a 45 degree.
Not much. So.
Still no?
Okay. No,
Oh, now you have. Okay, advance a bit more. Yeah, perfect. Now push your catheter, push your, there, go, push it, push it, push it. So now you're going to be in the space. Why? Because the actual angiocat have about like 1 or 2 millimeter above it of the needle. So sometimes you're going to be in the space, but your angiocat is not yet in the space. And now you can pull and you see there's more fluid coming.
Okay.
And then if you're
keep it
doing
up for
chest
you.
compression, what should you be doing? Let's say the heart rate comes back, the sinus rhythm, the saturation is better, but you're doing chest compression. Do you stop chest compression? Let's say you were doing this procedure when this patient was in cardiac arrest. But as you're doing the procedure, suddenly you see the SAT coming back and all these things. Do you tell your team to stop compression? What would you do? Or do you finish your cycle? You finish your cycle. The answer is always you finish your cycle. Why? Because you need to reestablish coronary perfusion pressure. Okay?
Okay.
I'll do it. I'll do it.
Okay.
I'm old. I can injure myself. Okay. Who wants to try it? Perfect. This. Okay. Oh, Phoenix, you're leaving? Okay, perfect. Ben, is it all clear for you?
All clear for me. It's very helpful.
Okay. Have you done it before?
No, knock on wood, no.
Okay, perfect.
But it's the one thing that you do look up all the time because you're like, if one day it comes, I have to know how to do it.
Yeah. And you have to know how to train your teams. The goal is
Yeah.
not to be the only one that knows how to do it because this can happen at any moment. So
Yeah.
you're locating your subxiphoid process.
Subtalar?
Yeah.
Yeah.
You know what? Maybe I can put you a xiphoid process. Let's see. Let's try to put you a xiphoid process.
Oh, yeah.
We don't have a lot of you see, like here we do with our low-key mannequins, not like in Florida where you have a lot of resources. I'm kidding.
Look.
Yeah, that's your xiphoid process. Yeah, you can yeah,
Ouais, non, mais on
perfect.
suit.
It's exactly this. I would say in tiny pram, like it's gonna be very close to the skin. You're talking about like something like a few millimeters. You're already in the pericardial sac. Yeah. Because you see it on echo, right? Like when you do your subcostal, you're right away, you're in front of the atriums. Yeah.
There?
Yes. So, oh, you were not here when I said that? Yeah. So start poking.
Okay.
So we'll let her poke and then I'll answer again your question on blood.
Is that where's the shoulder
Yeah.
at this angle?
Yeah, 45 degree. Perfect. So advance, pull, advance, pull, advance, advance.
Closer.
Yeah. Perfect. Now push your catheter as you pull Yeah, perfect. There you go. Because the biggest mistake you could do is when you have fluid coming back, you don't push your catheter even more. And then you lose your space and your catheter is actually not in the pericardial space. That's the part that can be tricky. If it's blood, it could either be that you're intracardiac or it could be your effusion is a bloody effusion. So
So you keep pushing, and then at what point do you stop again?
Like a few millimeters, is that it?
yeah, so you add only the few millimeters. So it's typically like 1 or 2 millimeter. And basically
Okay.
what I do is that I push my catheter as I'm pulling my needle. So as soon as I have fluid coming back, I advance another 1 millimeter.
Yes.
I push my catheter and then I remove my needle. And then
Got it.
typically you'll see fluid coming back. The other
Got
thing
it.
I was asked is if you have blood. So typically I just said that in a baby, a term baby, a tamponade effect, you'll get it at like 3 or 4 cc. So if you remove 3 or 4 cc, you're not going to exsanguinate your kid, okay? And you'll remove if it's actually you're in the space and it's bloody. So what I would do if you're not doing it under ultrasound because you're less confident with ultrasound, you remove your 3, 4 cc, you finish your cardiac compression cycle, you reassess. Do I have an infusion? Do I don't? If you're doing under ultrasound, you'll see your needle coming in. So you know you're in the space, okay? And you'll see the actual fluid reduce. If it's a preemie, 2 cc will be enough to remove the tamponade effect. So if I see blood, I'll always first say, okay, maybe it's bloody effusion. I'll remove my 3, 4 cc. Anyways, I know this kid will need some preload after that. I'll probably, once I have either pulled my PICC line or placed another venous peripheral access, I'll give a bolus of 10 cc per kilo because you're going to probably remove the equivalent of like 10 cc per kilo. Because if you remove 4 cc, in a preemie baby, that's already 5, 6 cc per kilo. If you have a 4 kilo baby, then it's 40 cc, so it's like half of a preload, but you probably congested a lot for a bit, you know, so it's all these things that you need to take into account. Okay, so try the procedure. What time is it?
3:17.
We have 10 minutes. We have 10 minutes to briefly. Oh, I think you remove yourself too quickly.
Yeah.
Okay, now push, pull, push. Yeah. Now push your catheter, and as you're, advance your catheter as you're removing your needle. Perfect. Remove your needle. You have fluid coming back.
Yeah.
Beautiful. That's the technique.
I needed to be there just in case.
Perfect. Everyone save the baby. There you go. Give me the needle. I will safeguard it. And then this we can throw. Okay, let me just bring this to the sharp containers. Yeah, we can just throw the garbage and then we'll finish 10 minutes talking about briefly another update. Leila, did you try?
No, I didn't. I just, yeah,
You don't
I
wanna
do it on the patient all the time.
You do it on the patient?
It's okay, you need to wrap up for 10 minutes. I attended the workshop multiple times. The 17th, yeah? Yes. I remember Dr. Bonnier who we had a student. Yeah. Oh my God, it was like he blindly went into there.
Okay. So now we're going to briefly talk about another. So I think you saw how this patient, so that was the example of the real case. Actually, you see the fluid look like this. This is like a kind of a TPN type of fluid which looks very milky. And you can even see like the PICC line, which is so sometimes X-ray can fool you, and especially with PICC lines, if you install it the next day, you can have like with the heat of the body, you can have migration. So you may have a good X-ray from yesterday, and maybe actually it was intracardiac, especially in preterm infants. So you have to be careful. Okay, and hopefully you realize that some of these presentations, I mean, you're at the bedside and it could be cardiogenic, it could be so many like preload issues, IVH, you know, so sometimes some of these techniques can help you prevent going down the rabbit hole. So this patient, you drain and he's back to normal. And probably the next day he's back on CPAP and he's full PO and he doesn't need his antibiotics and stuff like this, you know. Okay, 26 weeks P-prom, 4-week maternal fever, choreo, cord pH 6.9, basic S minus 26, intubated delivery room, chest compression, epi, receive surfactant, right away in severe hypoxic rest failure, mean of 9, FiO2 100%, mean blood pressure via the UAL, which is a postductal blood pressure, gives you around 17 to 19 with systolic of 27, diastolic of 10. So low systolic, low diastolic, low mean. And then, they're starting NO because of this pre and post differential of SAT. The kid has very high lactate on the cord, and your first hour and 2 hours, you have 19 and now 24, so it's climbing. And now he spent the entire night with pH less than 7.0. So they're calling you because they're thinking, well, this kid is not doing well. He's hypotensive, he's INO, he has PPHN, maybe he's on 100% oxygen, his lactate is increasing. What are you thinking? Okay, so you're thinking sepsis. So what would you do? Bolus? Okay, antibiotic. For sure, this kid is on antibiotics. So, okay, so you want volumes? Which kind of inotropes you want to start?
Low dose epi.
Low dose epi, okay.
Even norepi, like he has wide pulse pressure.
So you want norepi because of the wide pulse pressure. Diastolic pressure is very low, so you're thinking maybe for coronary perfusion, okay. So you're thinking SVR is an issue in this patient?
Well, you don't know.
Okay.
Just worried to increase the afterload on a heart
That's struggling, right? So you're putting norepi.
whatever.
Perfect. So one of the issue of norepi is that it has, if you look at the wheel of adrenergic, you have dobutamine and ipraprostanol at one end, which will act a lot on, your receptor increasing heart rate and, providing more contractility. And then as you go forward, you go to the other extreme, which is phenylephrine, which is a pure alpha agonist and vasoconstricts a lot and has no impact on your cardiac function, but will increase your SVR very high. And then you're kind of in the middle where you have norepi, which is a very potent vasoconstrictor, maybe a trickle of effect on cardiac function, but mostly vasoconstrictor. And in the middle, you have a bit of dopa and a bit of epi, where they act on cardiac function, but they can also act a bit on your SVR, PVR. Dopa also, the issue is that it can act on via epi and norepi pathway, so it could be a significant vasopressor. It's a more vasopressor than inotrope. So if you're looking at more supporting cardiac function, you would be more into the epi-dobu area. But dobu will mildly improve your contractility. So why not milrinone? Because he has PPHN.
Hypotensive.
Hypotensive, he's probably not peeing, he's anuric. So that would be really a problematic. Do we keep INO on?
He has which dysfunction, which part?
So what does
Hypotensive,
he's hypotensive?
and he's 1 day old.
Yeah.
The PDA is still open.
Well, you have a pre and postductal side difference. So if the PDA is not open, there's a problem why you're having a pre and postductal side difference. Because the only way you're going to have pre and postductal side difference is because you have a right to left PDA. So by definition, you have to have it open. If not, there's no point of doing pre and postductal sat, right?
INO is there. If the INO is this, if we have INO and the PDA is open.
Yeah.
Yeah, I know.
What could happen?
You're shunting blood from left to right.
From right to left. Here, you're shunting right to left. Because
Right to left,
you have,
but you're decreasing your pulmonary vascular resistance.
yeah,
INO.
yes.
I don't want to decrease my vascular resistance
Why?
because your blood is going from left to right. Because you're decreasing, you're decreasing your pulmonary
So
vascular resistance.
So with INO, you're encouraging flow from going from the aorta to the PA instead of the PA to the aorta. So your PVR to SVR ratio will drop with INO. Right now, your PVR to SVR ratio will favor a right to left shunt because you have a right to left shunt. But if you're trying, you want it right to left, you need to remove the INO. Why do you want it right to left?
I want it right to left because I wanna have circulation to the
Perfect. Yeah, that's good. Okay,
the
good.
body.
Okay, so you start your echo, you see your UA, you see your UV. Okay, so what do you see on this echo?
Not perfect contraction.
What is this? Okay, let me bring you here.
You have depressed ventricular function, yeah.
Yeah, severely depressed ventricular function. That you see the atrioventricular valve, they barely open, like in the sense they open, but for like a fraction of a second. You see your aortic valve also that opens for a fraction of a second. You can see it here. You see your pulmonary valve looks like it barely opens. So when you see these valve opening time are very short, it means the flow through it that is being generated is very short-lived. So the cardiac output is likely severely depressed. I can tell you the cardiac output was severely depressed. This is the TAPSE. Your shortening fraction was 12%. Your ejection fraction was 10%. This is your LVO. So you have an LVO it was calculated, I think, at 65 cc per kilo per minute. You also see significant, this is aortic insufficiency. So although you have some forward flow, part of this forward flow actually comes back to the left atrium, to the left ventricle, and this can increase also LV and diastolic pressure, and you end up with mural wall tension and coronary hypoperfusion. You can see there's a trace pericardial effusion. I don't know if you see it here. That's not enough to create any kind of compression. Also, by the way, pericardial effusion, you never measure them in systole. You measure them during expansion because it's a diastolic disease. So you measure them during peak of relaxation. This is the duct. So you see the duct is wide open here. It's completely right to left. I've put an M mode through it where you see that it's blue, 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 blue. Maybe you get a little trace of red sometimes. This is by Doppler to quantify the velocities. So this is an M mode through the duct with color. So you see the color superimposed on the M mode. This is the velocity. So you can see that you have this right to left and almost no left to right. Like, I mean, this is almost zero. So it's a primary right to left shunt. And the reason there's a right to left shunt is that this patient has poor systemic blood flow. And then right now, this PDA is actually systemic because there's probably a component of abnormally high PVR, but there might be also a component of RV providing systemic output. So having INO in this context may be detrimental. So of course, this is a patient you may consider, depending on the stability of the baby and depending on his response to NO, to actually wean it to provide forward flow. Okay. But the concern here is that there is biventricular dysfunction, but because the LV function is terrible, I would probably remove the INO. The other thing you see here, there's bidirectional PFO. So this is because of the biventricular dysfunction. So if this kid was term, what would we do in terms of management? Call for ECMO. Absolutely call for ECMO. If this kid was term, you would start prepping your teams for ECMO. You would probably do head ultrasound to make sure there's no big bleed in the head. You would have obviously talks with the family because this is a likely severe asphyxia and they may not want to go to ECMO in that context. You would check if there's severe seizure. This kid was seizing, so he was also on top of it receiving like pheno and all these kind of drugs, which can have an impact on your SVR. So for that reason, we weaned the INO. We started epi, like 0.05 to vasoconstrict a bit and counteract some of the effect of the pheno and all these things, but to support cardiac function. But because this baby was preemie, he was considered non-eligible for ECMO. Because here we do ECMO starting like 34 weeks and up.
Here the same.
Yeah, so we would not do ECMO on a 30-weeker. So there was poor RVO. I didn't put the RVO, but the RVO and the LVO were both terrible. So poor RVO, poor LVO. So, weaning of the INO to try to maintain systemic flow, provide inotropy to your cardiac dysfunction. These patients can be tricky to manage. So, epi plus or minus sometimes will even add a trace of dobutamine, but you have to be careful if they start becoming very tachycardic, which they can with these agents. Sometimes some people are concerned about like the lactate and the hyperglycemia with epinephrine. I think in that case, you don't have a choice to not give adrenaline as a support for the cardiac function. And then the other thing I want to mention is probably like because of the asphyxia, some of these patients may have adrenal hypoxia. And so, in our practice, we would likely be very early at giving hydrocortisone to this baby, which we did, to try to, especially in the context of prematurity, promote the adrenal function. And then this is a kid you want to like monitor, like a bit like what we did well, I don't know if you remember with the other baby, like you're at the bedside, you start your inotropes, your cardiac function, you reassess your cardiac output, you check what's happening. And this is not the kid you want to bolus and give tons of fluid, right? You have to be very cognizant about the fluid you administer. So this is a kid that with the asphyxia will likely have a component of DIC, bleeding, like who knows. So I can tell you this kid had platelets of like 8. He had like an INR of like 7. So this is a kid who, of course, you're going to have to give some kind of blood product. So you don't want to start giving like NS and like all these kind of empty fluids when you're eventually going to have to give blood products to replace and compensate to avoid like the bleeding and the IVH and all these things. So this is an example, I think, for me, of biventricular dysfunction, which you would include under the umbrella of cardiogenic shock. And, you would measure all your metrics of systolic function. So here, by that, I mean, like, we measured our TAPSE. We did measure the FAC. It was something like 12% as well, or 14%, if I remember well. So but I think globally, you see there's a global cardiac dysfunction. And what's important, I think this sweep is very important because you go up to the apex and then you come back to the mitral valve, and it really tells you that there's like it's not a segmental cardiac dysfunction. You have septal dyskinesis, the entire LV is not moving. You have global akinesia. So it's important to be aware of that. It just tells you the capacity for this LV to recover and how your degree of suspicion, especially if you consider ECMO. These patients are much less likely to respond to some of your medication. You would still try. It's also a patient you would want to make sure you're seeing your coronaries. So in some of the views, we look like, for example, here you have the long axis, but we see very well eventually the coronary here. We kind of saw it in the sweep. And then in your short axis, you would see your LC and your RC. Just make sure there's no clots, there's no weird things. Typically, these patients, you see very well the coronaries because they have high right atrial pressure. And because of that, it stents kind of the coronary system via the coronary sinus. So in asphyxia, it's very common to see very well the coronaries. We can see the RCA, but we didn't see the LCA in this view. So yeah, it's already 3:36.
So this was asphyxia?
This was preemie with asphyxia, and I think if I remember, well, there was also maternal choreo fever, so it could have been a component of infection, cold shock, but this was considered, I think this kid had very significant D cells, and then they went on arrival, this kid had very significant D cell. He didn't even have like beta-metazone, and it was like a significant kind of asphyxia. Okay, was that clear for everyone? Sophia?
Yes. Thank you.
Okay, thank you. Was this useful?
Yes, a lot.
Okay, I'm gonna stop.